We start. So welcome everyone to this meeting within the ESTM webinar. And today we're going to talk about invasive registrations, and the theme are how to maximize results and minimize complications. And today the topic is invasive intracranial monitoring. We have two distinct speakers. We have Francesco Cardinale. We all know him well, always call him Chico. And he is, as most of you know, the neurosurgeon at the Claudio Munari Hospital in Niguarda in Italy. You have to correct me, Chico, how I pronounce it. And he's very much focused on the stereo EEG monitoring and planning of stereo EEG electrodes. He has a focus on neuroimaging for surgical planning. And after Chico, we have the honor to hear Joseph Comer, who has got his education in Montreal and has been at the UCLA and also been at the Cleveland Clinic Foundation. He is presently Professor and Chair of Neurosurgery in the Lebanese University. The rules are that we listen to both presentations. We start with Francesco Cardinale, about 20 minutes, and then Joseph Comer will continue immediately. Any questions you have, we ask you to put on the chat, and I try to sort of give the questions to one of the speakers. And if there are remaining questions, sometimes we can try to send responses out with email. So I stop sharing, Chico, and you are welcome to start the presentation, Francesco.
Okay, thank you. First of all, of course, thank you everybody. I will try to not to lose time, so I immediately try to share. Okay. Do you see my first slide?
Yes.
Yeah. Okay. So I'm going to show you all our workflow about surgical techniques in SEEG, and okay. I want to thank you, the organizers, for the kind invitation, and of course for the perfect scheduling about our speech, perfectly simultaneous to the AC Milan Inter Milan match. So we will see in the future when organize the other meetings. Jokes apart, I'm trying to show you our workflow at the Claudio Munari Center in Milan. This workflow is named 3-dimensional 3D ERA, that stands for Imaging and Robot Assisted Workflow. First, we have the stereotaxic planning. I will run very fast on this part. So we convert DICOM files in nifty files or MGZ files for volumetric arrangement of data. We use as the basis for the anatomy the typical 3D T1 MR scan, high resolution. We still have only 1.5 Tesla MR, and we co-register to this 3D dataset all other datasets, such as flare scans or spatial datasets such as PET scan, DTI, functional MR, and so on. We also process the images with some functionalities of very famous softwares. This is, for example, the result of the processing of made by Freesurfer that is very helpful to segment the hemispheres and to do the 3-dimensional estimation of brain surface. Very helpful, especially in situations like this, where you the anatomy is heavily altered, and it's very difficult to understand the anatomy only onto the slices. About vessels, we do catheter angiography with the arm. Now we are moving to a more conventional modern equipment, but the idea is to have three-dimensional data set. We acquire a bone mask, and then the data sets with injection, selective injection in the carotid artery and in the vertebral artery when needed. And we subtract the bone mask, and we have a three-dimensional reconstruction of the brain vasculature. Here you can very quickly see some comparison here on your left between the arm acquired angiography against a conventional CT scan with the peripheral injection of contrast medium. You see that the contrast is probably much better with the arm because of the selective injection in the carotid artery and because of different radiological parameters. And on your right, you can see here the subtracted three-dimensional CBCT angiography with our technique compared to gadolinium enhanced MR. You can find the details of our technique in a paper published some years ago on Words Neurosurgery. Once we have this vascular dataset, this is the reference dataset. We co-register the 3DT1 MR datasets to the vascular space, and all other datasets that were co-registered to the 3DT1 will follow the same destiny. So everything in the space of the vascular datasets. After the processing has been finished, we convert back to DICOM files in order to upload the files in the stereotaxic planning software. These are some screenshots taken from the planning with Voxim, one of the available software embedded with the Neuromate, the robot assistance we use. Here you can see that we have simultaneously the multiplanar reconstructions. Here we have now 50% faded on MR, 50% faded on angio. But what we find very, very helpful is this three-dimensional reconstruction of the brain derived from Freesurfer segmentation and a three-dimensional rendering of the brain vasculature. This is very helpful because in order to select the entry point, the cortical entry point, we have just to click on the three-dimensional reconstruction. This is the same, but 100% faded on angio, and this is the same, but 100% faded on MR. In these cases, in this view, we are seeing the projection of the trajectories, but we can change the view. And here we have some angiographic slices completely reformatted all along the trajectory plane. And it's very important to have both views, the so-called trajectory cut, and these are very helpful, the surgeon's eye view. So we are orthogonal to the trajectory in order to check for potential vascular conflicts. We pay particular attention to the cortical entry point because that is the very risky zone. So in the first millimeters of the trajectory, we don't want to have any vessels in an area of about, with a diameter of about 5 millimeters. So here you can see that, for example, we can enlarge the diameter of our virtual probe in order to check this avascular area. The planning is done some days or weeks before, some days or weeks in advance respect to the plan, to the true implantation. The day of the implantation, first, here we see Laura Castana, my colleague, my friend. She is now fixing the head into the Stylet frame. Of note, this is very important. We still use the Stylet frame, but it is not it must not be considered any longer a stereotactic frame. It is just a very rigid, very robust head holder in our workflow. Then, because the stereotactic space is the robotic space, so then we fix the head holder to the robot. Once everything is fixed, we put some fiducial, some skin fiducials. You see, we put some of them. We will see why in a few slides. Then we have to register the patient. What does it mean to register the patient? It means that at the end of the workflow, the planning space must be aligned to the robotic space with the head inside the robotic space. So we use this tool that is called Neurolocate. It is attached to the robotic arm, and then it is approached very close to the head of the patient without touching the head of the patient. So it is a situation of frameless, touchless registration with the unique situation in which the fiducials are not fixed to the head of the patient, but they are fixed on the arm of the robot. I take the opportunity of this picture to let you note that we have removed, in this case, one of the 4 poles of the head holder, because in this case, we wanted to have this region more free for electrode implantation. With the Neurolocate registration, we can use also, as you see, other types of head holders without any coordinate systems. Then we approach the arm scanner. Everything is compatible in terms of volumetric dimensions and size, and we acquire a 3D scan. We check that all the fiducials are in the 3-dimensional dataset. And then we have to register the patient. What does it mean? That we manually select the 5 fiducials. There is an automated optimization of the center selection, and this allows to do the registration because we select into the images the position of the fiducials, but since the fiducials are attached to the robotic arm, the system knows which are the coordinates in the robotic space. Before going on, we use these the skin fiducials markers. I mean that we plan at least 2 trajectories targeting the fiducial markers, and then we check that the robot with this laser beam correctly targets the fiducials on the skin. Because every time I say stereotactic minimal invasive approaches are fantastic because they are minimal invasive, we don't see anything into the head of the patient, but the drama is that we don't see anything into the head of the patient. So we like so much to have a visual verification of the fact that all the workflow is successful. Then we remove the arm, and so now the system knows where is the head of the patient, but still doesn't know where are the trajectories. So we co-register to the actual dataset the planning datasets with that had the planned trajectories. We check very carefully that the co-registration is almost perfect. Then we can move the trajectories from the planning datasets to the actual dataset, and we can go on with the true implantation. Here you can see on the monitor of the computer the position of the robotic arm moving from one trajectory to another. Okay, we check that the plane and the position of the robot perfectly match. And here you can see really the robot moving. So now it is moving from one trajectory to another trajectory. Once we are in position, we first do a pilot hole drilling with a special drill that has a large body and a very thin but very short drilling tip it is very solid and that does not bend. So once we have done the pilot hole drilling, we move on to do the proper drilling with this thin drill with the exact diameter to implant the guiding screws. So we manually enter the pilot drilling, and then we attach the engine of the drill, and we perform the complete hole into the skull. Then we do what is the most dangerous part of the implantation, that is the dural hole. We use a monopolar coagulating electrode, you see, with a tip that is not insulated, so we can burn the dura with this monopolar coagulator. Then we fix the guiding screw in position. It's a hollow guiding screw that is tightened into the skull. And it's called guiding screw because it is not only an anchor bolt, but it's only the tool that guides the trajectory of implantation of the recording probes. Once we have implanted all the guiding screws, we remove both the head holder and the robotic assistant, because we like to implant the electrodes under X-ray control. Okay, so here you see the careful removal of the robot, and then we go on with implantation. So the arm here is again in position. First, we do an intracerebral track with the stylet, a rigid stylet. Okay. And then we remove the stylet and immediately advance the electrode, the multi-lead electrode, into the brain. And in most of cases, the lead will follow exactly the track of the stylet. Why we use first the stylet? Because the electrodes are semi-rigid, so they could bend because of brain cell size, something like that. We like to do this under X-ray control exactly to check if we have deviation of the electrodes and at least roughly if the depth of implantation is correct. At the end, we acquire a new data set with the electrode in position, and thanks to simple segmentation techniques, we obtain the model of the electrodes, and we built these multimodal scenes with the three-dimensional reconstruction of the brain made by Freesurfer, with the brain vasculature and the position of all the leads that are very, very helpful. First, to our epileptologists to understand where the traces come from, and then again for the multidisciplinary meeting to discuss the final subject. We remove the electrodes at the bed of the patient some days when SEEG monitoring has been finished. We don't use any longer local anesthesia. It's much better to do everything very quickly. This is a young girl. You can see here when the screw is very strongly tightened, it's better to not to force too much inside the screw, but first to untighten it a bit with this special key, and then to remove with the screwdriver. About the removal, I have a first suggestion. This is what can happen if you do the removal in sitting or semi-sitting position. You see how much air can enter the brain, so the removal must be done absolutely in supine position. So no sitting position for the removal. I take the opportunity to give some other tips. I suggest to absolutely to avoid the prone position during the implantation. I heard about some hematomas in some centers that to me are related to the use of prone position. Since all image datasets are acquired in supine position, please avoid prone position because you can have brain shift and, more important, vessels shift that could lead to hemorrhagic bleeding. So avoid prone position. This is a picture depicting, courtesy by Dixie, depicting the difference between proper SEEG electrodes and the classical depth electrodes. You see that the SEEG electrodes have a smaller diameter, so are less traumatic. The spatial resolution for the recordings is higher. The tip is recording, so we have a recording lead on the tip of the probe, but the SEEG electrodes don't have a stylet inside, so we have to use the stylet before to avoid bending of the electrode intracerebral. The recording tip is important because, for example, when we want to record from the cingulate gyrus cortex, we need a recording tip. Otherwise, we will be obliged to go over the cortex, the cortex. Sorry. We will have the possibility to touch very dangerous arteries, so better not to go over. Also, at level of the insular cortex, this is the situation. Normally, we prefer to go a bit over the insular cortex in order to have at least one or two traces that give us the pure insular signal without having a mix of insular and opercular cortex signal. About another tip is about electrode fragility. Here you can see the screw. All the leads are internal to the screw, so they are all intracranial. This is perfect. We can also have some leads inside the guiding screw. This is also okay. What you have to avoid is to have electrodes outside the screw, because this can lead to probe damage. Here you can see that this part of the electrodes without the leads is very flexible. Instead, the part of the electrodes with the contacts is much more fragile and can easily break. Okay, so you have to avoid to have leads outside the guiding screw. Otherwise, you will have the electrodes damaged in the first day of the monitoring. Very, very quickly, couple of minutes, no more, the results of our workflow. Out of more than 10,000 trajectories in more than 700 SEEG investigation. The number of electrodes throughout our more than 20 years activity has increased, probably because the more diagnostic modalities, the more the hypothesis to be verified. We use very, very rarely bilateral investigation, and I mean that especially symmetrical bilateral investigation are only 4% of our investigation. When we have a lesion, here you can see the most common MR abnormalities, such hippocampal sclerosis, glioneuronal tumors, and FCD type 1 or 2. The number of SEEG investigation has decreased a lot in our history. Instead, we use SEG more and more for MRI negative cases. And despite this, the results are getting better throughout the years. This could be surprising for some of you. We use less and less SEG in eloquent cortex. For example, this is the use of SEG throughout the years at our center in Rolandic and peri-Rolandic region. The percentage of patients that after SEG are discarded from surgery is still too high. We have to work about this. The results on seizures, we have about 60% of seizure-free patients after SEG against 80% in patients with not studied with invasive recordings. This is, of course, related to the fact that SEG patients are more challenging. We have a small percentage of optimal responders with the thermal ablations. And I want to conclude with this concept. In 2013, in this very well-cited paper we published, we mentioned an overall rate of complication of 4.8. In the last paper 2 years ago, we reported 1.8% of complication. What happened? Considering that these 500 procedures are included in the last study, what happened is that we reclassified complication, because it's true that the older paper has been cited very, very often, but many cited it just to report that we have this percentage of complication that honestly is not does not give the sense of the reality. This is a post-operative CT, a CT after a standard temporal lobectomy. We have a little amount of blood here. I think that none of you would consider this as a complication. So why we have to consider this after SEG a complication? This must be considered as a warning about safety, but it is absolutely not a complication. This is absolutely in agreement with the paper published by the Cleveland Clinic group, where they proposed a grading system for classifications. Grade 1 are the smallest one and without any symptoms. So they should not be considered the classification. So I would like to push you to consider our criteria in the BRAIN paper to classify complication. So to us, a complication is when we did a surgical treatment, we had a new neurological deficit, we had to abort the procedure, we had a potentially life-threatening event, or of course, the death of the patient. We don't want to hide the small events, but they have to be called something like notable events. And this is the rate of complication with the new workflow. We had no major complication specific to the neurosurgical procedure occurred with the 3D era workflow. I conclude thanking so much Jean Talleyrand, who was the true father of image-guided surgery, and Claudio Munari, the founder of our center and our method. Thank you so much.
Thank you so much, Jacob, for this elegant and instructive presentation. So now we continue immediately with the presentation by Joseph Komar. Please, Joseph, can you share your screen and continue, please?
One second, please. Thank you. First, thank you very much for asking me to join you and discuss subdural electrodes. It is a pleasure to be with this group. I will start first by talking about the history of subdural strips and grids. Perhaps it offers a perspective on now the usage of strips and grids and the continuous controversy between SEEG and subdural. So the first subdural electrode used was by Penfield and Jasper in 1940. But for some reason at the Montreal Neurological Institute, when I trained as a resident, we never used subdural electrodes. All invasive investigations were with SEEG by Dr. André Olivier, and mostly for bitemporal epilepsy. Angemoni, Marsan, and Van Buren contributed a lot to the development of invasive technologies in the US. In 1958, they published a paper. And then it's important to remember Sidney Goldring, who popularized epidural grid monitoring for pediatric epilepsy and published a very long series, almost 100 patients, many of them children with intractable epilepsy. This was in 1978, so a long time before we started pediatric epilepsy surgery. And then a group of people, Alan Weiler, John Gervin, and at the Cleveland Clinic use subdural grid electrodes for invasive monitoring. And this started almost like the American school of invasive monitoring that was different from the European school that Chico very elegantly demonstrated. So what are now the current indications for subdural electrodes? I believe the current indications are as a cortical lesion with ill-defined epileptogenic zone. And it's important that the lesion, again, is cortical, that there is a need for cortical mapping that cannot be performed with an awake craniotomy. And also, similar to SEEG, there should be a reasonable anatomo-electroclinical hypothesis before a subdural electrode is placed, because placement of subdural electrode haphazardly will result in a negative investigation. So in selecting the patient, it is important to look at this paper from Prakash Kotagal, who is an outstanding epileptologist at the Cleveland Clinic, who looked at the value of seizure semiology in the lateralization and localization of epilepsy. And he compared it to scalp EEG, MRI, and PET. And surprisingly, as you can see from this slide, the semiology correctly lateralized the patient, as well almost as MRI. Only ictal EEG lateralized the patient better, and also semiology localized the patient as well as any other technique. So it's very important before planning to get a very, very good history from the patient and get all the information together before the placement of the subdural electrode, again, for proper placement of the subdural electrode. Now, subdural strip electrodes, I think the current indications should be limited to their use in combination with subdural electrode in the interhemispheric area, basal, and we'll come back to this. Bilateral insertion of subdural strips carries a very low yield and should be replaced by SEEG nowadays. What are the advantages and disadvantages of subdural grid electrodes? The advantages is they offer wide coverage of the cortical surface, including the basal and medial cortex. They allow extensive cortical mapping at leisure. They can be performed in children and infants with thin skull. It is a simple surgical technique that most neurosurgeons can master, and it is accessible to most neurosurgical centers who are not equipped to do SEEG. And as you know, definitive surgery usually is performed at electrode removal. The disadvantages, and in our hands, it's poor localization, so of the ictal onset zone. In 35% of cases, the ictal onset is diffuse or not defined. and the ictal onset can be at the edge of the grid in 49%. And this is a paper from the Cleveland Clinic that is mostly described our series. So before I start with the implantation, I'd like to point out to this important paper that was published in 2002 from the Cleveland Clinic, which reviewed the experience with subdural electrode evaluation in 2 time epochs, the period from 1980 till 1991, and from 1991 till 1997. So when I joined the Cleveland Clinic in 1992, we were burdened with a very high risk or rate of complication in subdural electrodes. And we then implemented a surgical protocol that we continue to use that dramatically decreased the incidence of complication. And I will go through this protocol. And in this table, you can see this is the complications before 1992, and this is from 1992 in gray, from 1992 to 1997. It is exactly almost the same number of patients which were operated between 1980 till 91, and then from 91 to 97, from 92 to 97, exactly the same number of patients to 2 different periods. And you can see that the neurological deficit dropped from 13% to 10%, permanent deficit dropped from 10% to 2%, bleeding 1.5%, and decreased consciousness 2%, treatment required in 5%, and deaths 0%. And this is commensurate with now more recent series published in the literature. So what were the risk factors for subdural grid complications identified? The use of more than 3 grids, high number of electrodes, duration of the monitoring, so 13.1 days increased, so above 10 days increased risk of complication. Children did much better than adults in complication. Complications were noted almost exclusively in adults. Left side insertion led to decreased consciousness, paresis, etc., as compared to right side insertion. An additional burr hole placement for strip electrode was associated with high risk of complication, and year of implantation, as we discussed, 33% versus 19% of complication. And this is a paper written by a neurologist who went very thoroughly through any complication. So the operative technique is described in this slide. So we perform a wide craniotomy. We place the convexity electrode under direct vision. Intraoperative navigation can be used if the target is small or not well defined. And there is, so for interhemispheric exposure and basal temporal exposure, we expose the interhemispheric fissure very well, and also the basal temporal lobe very well, in order to look and check any vein before placement of the electrode. So the dura is closed in a watertight fashion. Dural sealant is used when necessary. And what I missed to put here is that dural stenting sutures are very important, particularly in the center of the bone flap. So I put several dural stenting sutures that I pull the dura back to the flap to minimize the pressure on the subdural plate. I use an epidural hemovac drain that I remove 12 to 24 hours later. I use a long tunneling of the cables, so we prep accordingly the head of the patient almost completely. We use prophylactic antibiotics throughout the monitoring. I use IV steroids for 72 hours and then stop them. At electrode removal, the electrode cultures and the epidural space are cultured. If the cultures are negative, the patient stays only 5 to 7 days, and if the cultures are positive, the patient is continued on IV antibiotics for 3 weeks. So this is the exposure for the subtemporal exposure, where we put like to see the basal temporal lobe well before we put the electrodes. We slide the electrodes with continuous irrigation, and we make sure that there is no bleeding coming out before we remove, close the subdural, the dural space. And so for the interhemispheric electrodes, we put the electrodes with approach visualization of the forks, but without touching any vein. And this applies also for the basal temporal lobe. We don't sacrifice any vein in the placement of the subdural electrodes. This is for occipital epilepsy. This is a patient with dual lesion. And you can see here the craniotomy that exposed the basal temporal lobe and the mesial occipital lobe. And we perform an entire wrap of the occipital lobe with a 2 by 10 electrode placed under the temporal lobe from posterior to anterior. This is the medial occipital interhemispheric electrode, and this is the electrode wrapping around the occipital lobe. So then co-registration of the subdural electrode to the anatomy is performed, and we then obtain an MRI and reconstruct the MRI for identification of the placement of the electrodes. So it is in the placement of subdural electrode, it's very important to understand the venous anatomy of the particular brain, because I believe that the problems are related to the convexity electrode that is placed mostly. I have never seen a interhemispheric electrode or basal electrode, if properly placed, creating problems. The problem occur from the convexity electrodes, particularly if we use a lot of electrodes over the convexity and the disturbance of the venous drainage that the electrode can create. So I try to understand very well the venous anatomy before I oppose the electrodes to the brain, and not to try to impinge on these on several veins at the same time, because I believe that this is where we run into problems of edema, etc. Also, the thin subdural clot that occurs contribute to with the pressure of the electrode to occlusion, progressive occlusion of the vein and of the veins, and the progressive neurological deterioration of the patient. And so I'm offering now a few examples of the placement. This is a 5-year-old boy with right frontal epilepsy, and an MRI showing a gyral anomaly in the right frontal lobe. It was not a type 2 dysplasia, it was more of a gyral anomaly. And he had, by chance, an ictal spec that demonstrated, you can see here on the ictal spec, the uptake. So we investigated him because of the ill definition of the gyral anomaly. We investigated him with a subdural electrode, and you can see here that I cut the electrode in order to have it confirmed to the particular brain anatomy. This is the interhemispheric, this is the interhemispheric electrode. And electrodes in Lebanon are very expensive, so I try to use a limited number of them, and that's why here in this particular case I use only one interhemispheric electrode. And so you can see that there was one electrode which has fast activity, but after clinical onset. So this was not the ictal onset area, and this was a propagation because of what Jorge described very well in his one of his recent paper, when the pathology is subcortical, the electrode will pick it only depending on the site of the dipole. If the dipole is perpendicular, the electrode can pick it immediately, or if the dipole is not perpendicular, the electrode will pick it with some delay. And this also explain why there was only one electrode picking it up and there was no propagation to other electrodes. So this is the resection. The second patient, this is a patient with Taylor type dysplasia in the inferior frontal lobe, very close to the speech area, investigated with electrode covering the frontal lobe, the basal, so the convexity, the basal frontal lobe, and the temporal lobe, and the ictal onset came from just anterior to the speech region, so the inferior frontal lobe, and the resection led to total control of his seizures. This is a case that I show quite frequently. This is a 19-year-old lady. Now she's much older, and with long history of intractable Jacksonian seizures that I'll show you, completely normal MRI. And I'm showing this case because to show how much anatomy is important in the selection process of the patient. And you can see here she's starting to jerk in her left hand. She's holding her left hand, and so she has a Jacksonian march. And so subdural electrode placed, and ictal onset came from exactly the hand area. This is in red, the ictal onset, and inside is the motor cortex. In blue here is the sensory cortex. So we went ahead and reoperated her upon removal of the plate under local anesthesia, resected the hand area, and this is the post-op MRI, spared the leg area. So face, hand area were resected, spared the leg area. Pathology was dysplasia, and she went on to do a very excellent recovery of her right hand. She was totally plegic in the right hand immediately after surgery. This is another patient that I placed in order to demonstrate that at times you don't need invasive electrodes. And you can see this is a 17-year-old female. Now she's an architect with a dysplasia in the left dominant cortex, in the sensory cortex, sparing the motor cortex. And you can see this is the motor cortex, and this is the sensory cortex. So the dysplasia spared the motor cortex, and she had seizures. Oh, so let me show you her seizures. So she has an aura in the right hand, and then dystonic posturing of the right hand, as you can see here, and then spread to the SMA rotation of the patient. And you can see it. So we operated. I thought if I can use a subdural electrode, but what it's going to show me that I don't know. Anyhow, what I can do more than resect this dysplasia and the primary sensory cortex, because anterior to it is the motor cortex, posterior to it is the speech area. So I thought I will proceed and resect under local anesthesia the dysplasia. And of note here is that when we use subdural electrode, coming back doing another surgery is very complicated, I find. It's not easy to redo surgery after the insertion of a subdural electrode, particularly in eloquent brain. And so that's why we proceeded with the surgery. This is the intraoperative EEG and the typical spikes of dysplastic brain. And this is, and this is few months after surgery. You can see here the neglect of the right hand. And I'm going to run the second video. You can see So just if you could watch, so she can still move her right hand very well, but finger approximation, I'm sorry, I'm not a very good video maker, but so when she opens her eyes, she can approximate her fingers very well. When she closes her eyes, approximation of the fingers becomes more and more difficult when she closes her eyes. So there is no weakness, but only a proprioceptive deficit. And you can see here, 2 years after surgery, she's an architect and she can use her right hand very, very well. So there has been a dramatic shift in the use of subdural electrodes almost everywhere in the world. And in particular, this is from London, Ontario, a center where almost exclusively subdural electrodes were being used. And progressively, in London, they have abandoned the subdural electrodes for the use of SEEG. And this is a paper, in fact, 2 papers from the Cleveland Clinic that compare 2 epochs, much like I did initially. So my epoch to the later epoch. And in the first paper, subdural electrode analysis in focal cortical dysplasia, this was published in 2007, but looked retrospectively at the cases performed previously. And diffuse ictal onset was noted in 38% of cases, edge of plate ictal onset in 44%, and seizure freedom was only 45% at 2.7 years. And compared to the more recent series published by Jorge, and that shows that the epileptogenic zone was better localized, 99% almost in subdural, with use of subdural as compared with SEEG, 77%. And seizure outcome was equivalent to SEEG, but better than the previous epoch, 70%. So there is still some controversy to the use of SEEG versus subdural electrode. I believe that subdural electrode should be used only in very, very selective cases, as I have discussed. And the overzealous use of subdural electrodes is dangerous. These are the cases that I see in our region. Patients are being operated bilaterally. Subdural electrodes are being placed bilaterally with depth electrode placed concurrently without proper guidance. And I hope that more surgical technique conferences will convince people that this should not be done anymore. So in conclusion, although SEEG has a proven superiority in the localization of the epileptogenic zone and less complication rate, subdural electrode can still play a role in the invasive EEG evaluation in carefully selected cases and in centers not equipped to perform SEEG. Thank you very much for the invitation.
Thank you very much, Josef. And we have some comments and questions from the audience. I will start, however, to have 2 comments. First, one to Chico and one to you, Josef. First, Chico, I completely agree with you that it's very important how to define a complication, because if you have a strip of blood after an electrode, okay, the patient has got some blood, but it's certainly not a complication. It has absolutely no effect on the patient. And then for you, Josef, as you know, we have my favorite subject is safety and complications, actually. And I think you listed very well, or I think very importantly, all these different things to be aware of when you play subdural grids. I used subdural grids until some years ago, but now completely shifted to SEEG. But I think another important thing is the surveillance after placing a subdural grid. We always use a nurse or nurse assistant sitting by the patient 24 hours, 7 days a week. And that is extremely important, I think.
Yeah, I missed to say this. It's very, we keep the patients in the ICU till they have fully recovered and they are totally awake. We monitor them in the ICU till we are convinced that they are totally stable.
Yeah, thank you. Then we have some comment from the audience. I have one from Yugoslav Ivanovic to Chico, and he says, Chico, is there any concern for the brain shift when implant your guiding screws? That's one part. And when do you obtain the length of the electrode? Do you use any antibiotics throughout monitoring? Can you comment on that, Chico?
Yes, sure. Okay. We are not so afraid about brain shift during the implantation of the guiding screw. What we do is that when we note that we have a certain amount of CSF leakage, we simply put a closing cap on that screw in order not to have too much CSF leakage. Then, in the second phase of the implantation, when we will have to really advance the electrode into the brain, first we will remove the cap, then we'll advance the stylet, then the electrodes, and then the final cap to close everything. About antibiotics, we do just one administration at the beginning of the procedure, no more, and we had just one brain abscess, one clinically relevant infection out of more than 800 investigation. I don't know, probably we had 2 or 3 very small skin infection just solved with local care. The other question, about the length of the electrode. Everything is in the planning, because we use multimodal planning. So we load in the planning software the MR, the CT with the bone, and of course the 3-dimensional angiography. So once we put in position the robotic arm that includes the tool holder, we define how far the robotic arm must stay from the target. So with very, very simple subtractions, we can subtract from this distance, that is, I repeat, the distance from the tool holder from the target point. From this distance, we subtract the recording distance, that is the segment of the brain where we want to have all the leads between the target point and the cortical entry point, and if any, the distance between the cortical entry point and the inner skull. This bone cortex distance, of course, is very, very small, almost virtual in most cases, but can be some millimeters when we have some atrophic dimples or previous surgeries, for example.
Thank you. And then for Joseph, we have from Massimo Cosso. He says, don't you think that the definition of coverage with subdural grids as wide could be questionable? Actually, cortex within sulci, approximately 2/3 of the cortical surface, is not accessible to direct recording, and that this is perhaps a limitation, especially for functional mapping. So please, Joseph, you have a comment for this?
Sorry, I did not get the question. So the question is?
The question is, Massimo argues on that the definition of a wide coverage with the subdural grids might be questionable, since you have lots of functions in the sulci where you actually don't get access by the subdural grids.
No, I also agree. It is, the subdural grid offer a wider coverage of the cortical surface than compared to a SEEG, because with SEEG, then you'll have to insert far more electrodes. Of course, I implied that the sulci will not be covered. Perhaps on average it covers in the placement area only 1/3 of the cortical surface. That's true, and perhaps I should have mentioned this.
Thank you. Then we have another comment from anonymous attendee for you, Joseph. And this anonymous asks you to comment on the implant of RNS responsive neuronal stimulation after subdural monitoring, or if you will do that, should you do that in the same situation as you do the subdural monitoring? I don't know if you have an experience in this, Joseph.
I don't, I don't have direct experience with the responsive treatment. So it's a responsive, what do you call it, technology. But some of my colleagues were using it, and I am first not very impressed by the results of responsive technology. Second, in order to put responsive technology, you have to think very carefully of the pros and cons of this before, I think, even inserting the subdural electrode. We place subdural electrodes with the intent of doing resective surgery. If the ictal onset is very wide, responsive technologies don't work very well, in my opinion.
Thank you.
I'd love to, if some of the panelists can comment on this.
Does anyone in the panel have experience with RNS and also in correlation with subdural grids, please? Or anyone else?
So, Berto, I agree with Dr. Comer. I think the results with RNS are very, very poor. It's a palliation, and I think Dr. Comer cases very clearly show that the fact that the epileptogenic zone is located in Rolandic areas is not a contraindication for resection, and with a very good seizure and functional outcomes. And I think sometimes there is a distortion because there is, in some centers, the availability of an RNS, which is a palliative procedure. So I just want to emphasize the importance of first offering a curative procedure for the patient with very good outcomes and functional outcomes, instead of offering first the palliation, which will not provide the seizure outcome. So I think it's a very valid point.
Thank you. And Joseph, I have to add that I became very, very impressed by your elegant presentation of your resection in the eloquent cortex. That was very impressive, I must say.
I just want to mention that although the results of RNS are truly not comparable to resective surgery, there is a conceptual advance by using the RNS system, which is the ability to get very prolonged ECG, electrocortical graphical recordings, and in these patients that can change the way we looked into epilepsy and epilepsy surgery. And it's highly likely that in the near future, we are going to be doing, instead of doing 1 week or 2 weeks of invasive recordings, we are likely going to be doing very prolonged invasive recording, like chronic invasive recording. So not to mention the results, because I fully agree with Jorge that the results are not comparable, but there is a conceptual issue embedded in the RNS system that could be very useful for us in the future.
Thank you, Otto, for this comment.
Comment on that, Bertel? I think that first off, I'd refer the people viewing to the excellent talks last month on RNS and on DBS that Arthur covered, as well as Jason Gerard from Yale. But I think the question also was, if you've put in a subdural system, electrode recording system, what do you do with RNS at the end of that if you're going to do it? Yeah. And I know that there are some centers that are doing the whole system at the end, when they explant the electrode. I think depending on the time of the implantation, because as Youssef was saying, the longer implants, there's a greater potential infection risk. But as he also said, it's not fun to go back and reoperate once the subdural space is healed. And so I think at the time of explant, at a minimum, you should be considering, if you're going to do RNS, leaving your RNS electrodes in when you explant the subdurals. And then if you're not comfortable doing the actual implant of the generator and ferrule, you can come back and just open the scalp and do the craniectomy part, but you could leave the electrodes in when you pull the subdural electrodes. And I think that's a reasonable compromise strategy in these cases.
Okay, thank you. Then we go back to
just
yeah, sure, Arthur, please.
Yeah, well, maybe if you are considering this, maybe you could do it in any way that you do it when you plan to come back. You just change the dural surface for a dural similar, and then there are many of these dural similar materials that you just leave there, and they don't attach to the brain. So if you plan to come back, just take the natural dural out and plus replace by an artificial one that does not attach to it, and you're going to be able to come back very easily.
Okay. Thank you, Arthur, for this comment. Then we have some comments and questions regarding SEG, and one is for Chico. Is oblique trajectory for SEG safe, and how often is it required? Please, Chico, what is your comment on this?
Sorry, I've not understood. If I do what with the trajectory?
No, that was a question. Is a oblique trajectory for SEG safe, and is it often required?
Yes, of course. This is a quite diffuse debate, orthogonal or oblique. In the past, we have to understand about orthogonality. In the past, SEG electrodes, most SEG electrodes were orthogonal to the mid-sagittal plane because of the tool holder. The tool holder was a double grid of solid metal attached to the Talay-Rack frame. But even in the early years of SEG, it was possible to attach the double grid of Talay-Rack to a special support to have obliquities that could be on only one plane, coronal or lateral, with the classical Talay-Rack tools, or it was also possible to have double obliquities with the Scherratis arc. Today, we use for all the trajectories, 100% trajectories, the robotic assistant. So I would say that we don't implant any longer any purely orthogonal trajectories. Of course, we can say that most trajectories are quasi-orthogonal. I mean that we have slight obliquities that are optimal to enlarge intervascular spaces in order to have a safe cortical entry point, but the strategy of your implantation is quasi-orthogonal. Quasi-orthogonal trajectories guarantee a good familiarity because most of the experienced SEG teams have learned throughout the years to interpret the position lead by lead of quasi-orthogonal trajectories. But anyway, we use also now a lot of oblique trajectories, and I would say that absolutely there's no difference, no difference. What is important is orthogonality or obliquity to the bone. It's important because when you are too much tangential to the bone, the risk of skiving of the drill is higher, and you can go out of your planned trajectories, and the entry point can deviate from the planning considerably. That's why we try to be as orthogonal as possible to the bone, not to the mid-sagittal plane nowadays. And when it's needed to go tangential to the bone, it becomes really more important to use that special drill that I showed you to make a pilot hole. I take this opportunity to answer another question that I read on the chat from Bob Gross that correctly asked where is it possible to have that drill. That drill is manufactured by Dixie, the one we have, but it is not part of the SEEG equipment. It's part of the Bengan kit, so the equipment manufactured for DBS implantation and developed by our close friend Benabid.
So Berto, can I just add what comments? I think this point is very important. I just want to emphasize, I completely agree to everything that Chico mentioned about the relation between oblique and orthogonal electrodes for SEEG. And I think Chico was very clearly in illustrating the surgical aspect of the orthogonality versus the oblique. But it's important also to complement this, that the implantation also serves the interpretation of the seizures by the epileptologist. And it's important to have this mesiolateral mapping, orthogonal orientation many times. So for us to understand, I'll give an example, the relation between the SMA versus the superior frontal sulcus, or the relation between the insula, the subcentral areas, and the opercular areas on the frontal, parietal, or temporal operculum. So those are relations that are very, very important to maintain and important for the interpretation of the epileptogenic zone by the epileptologist. So the quasi-orthogonal orthogonal electrodes, as Chico mentioned, it's an important factor to promote this adequate interpretation of the SEEG by the epileptologist. If we implant electrodes in highly oblique trajectories without any rationale, especially mapping the mesial versus the lateral cortex, the interpretation will be very, very difficult. And the results of the SEEG evaluation will be misleading. So I think I just want to add that this is also important for the epileptologist, the way we implant the electrodes in quasi-orthogonal orientation.
Thank you. And we use both oblique and mostly orthogonal in Gothenburg, but I completely agree with all these comments. Then regarding the possibility of a temporal pole, we have a question for Joseph. To Professor Comer, what are your thoughts of coverage of the temporal pole with subdural grids? And any tips on adjusting or cutting the grid into the right shape to accommodate the curvature of the pole?
Well, so the pole is very important to cover in neocortical epilepsy if you choose a subdural electrode, and because it can be the integrator of seizures. And I usually use strips in order to cover appropriately the temporal pole. So I put, a 2x6 or several 1x6 or 1x8 to look at the pole. It is also dependent on the particular venous anatomy of the patient.
Thank you. And then a relevant question for this, is there a risk of cutting the leads when you cut the grid?
So I cut the grid, with paying attention to the particular wiring. So you can cut the grid, and leave the wires totally intact. There should be no problem.
And then we have I think, a really great question here. Is there any advantage of subdural grids versus SEEG for mapping language motor? Now we haven't, this is not the pros and cons, but you have both given your thoughts of this, but please comment on this, anyone from the presenters or the panel who wants.
So I think the grid offers better mapping of speech areas than SEEG. With now small electrodes, you can do a reasonable good mapping of the speech area with subdural electrode as compared to SEEG. With SEEG, you will need to place several electrodes in the speech area, especially in the Wernicke area.
Thank you. And Chico, you have any comment?
Yes, sure. Of course, I do not totally agree with Joseph on this point, because, we don't have any personal experience with subdural grids in Milan because we never used subdural grids. Anyway, as was previously mentioned, with the subdural grids, you miss there's 66% of the cortex that is buried under the cortical convexity. But most important is to think about anatomy. I mean, even in the past with the fantastic stereoscopic angiography made by Talleyrand and Cicla, or today with all the softwares we can have fully reliable three-dimensional reconstructions of the cortical surface. So first of all, the focus, the area of our research of speech function can be strongly restricted to the study, to the three-dimensional study of the brain surface. Second, with electrodes, we can go, with the SEEG electrodes, we can implant them, we can have recording leads also in the bottom of the subside and also in the main white matter bundles. That is sometimes very helpful also for white matter mapping, even in case, for example, of corticospinal tract. What is true, and I finish, what is true is that we have to adapt the density of our electrodes to the goal. So if we want to map as accurately as possible the function, the speech area, especially Wernicke area, because we understand that we are going to do a resection in that zone, we have, of course, to increase the number of SEEG electrodes in that area to have a coverage that is enough to understand the function of the region. But this is one of the main advantages of the SEEG implantation, that we can adapt to the density of the implantation, and if the technique is really safe and accurate, we can be very dense also in a region very crowded of vessels, such as the periopercular region, that is the region where we have both Broca and Wernicke area. The only situation in which I think we are really troublesome are some large perisylvian polymicrogyric situations where there are so many vessels, so large veins, that the cortex is really hidden, and it's impossible to put so many electrodes. But in that situation, it's the same problem is also with subdural grids, of course.
Thank you. Then we have two questions for you, Chico, which we could take in one, because they are both regarding the safety aspects.
Earl, can I add one comment on that last question?
Sure, please, guys.
You know, I think that when you have, particularly for language, that there may be a hybrid model too, where depending on how strong the hypothesis is, you can do your SEEG implant, find what you find, and then you can debate based on the patient's ability to tolerate mapping. You can either do an intraoperative awake craniotomy when you do your resection, which avoids the need for potentially the subdural mapping, or if the patient won't tolerate that, then I think, as Youssef was saying, you can do a much more restricted grid if you want a more grid environment for mapping neocortical language. So I think most of the times now, if language is a strong part of our hypothesis, we still start with SEEG, and then we use potentially a smaller grid or intraop awake mapping if we need to in the second stage.
Thank you.
Let's not forget the possibility of stimulating with SEEG electrodes also immediately subcortical. I have to say that we have never done awake surgery also in language area, because every time we have been satisfied with the SEEG mapping, coupled with the very careful reconstruction of the anatomy and, of course, functional MR and everything we can have from more modern imaging technologies.
Can I make a comment?
Sure.
So if I am dealing with, you know, a process that is adjacent to speech, you know, attached to speech, I believe that it is important to do surgery awake. if the process can be half a centimeter away from speech, then you can, map by either SEEG or subdural. You can do the surgery under, general anesthesia. Speech mapping can be very tricky because you need to go up to after discharges. More frequently, you cannot do speech mapping at low voltage. Speech is a multi-synaptic process. It is not like other brain function, which is a almost mono bisynaptic functions. So you need to apply very high level of electricity in order to very carefully map speech.
Thank you. And further comments on this subject from the panelists?
Sorry.
Do we have any further? Yeah. Okay.
Go ahead, Christian. Go ahead.
What does the panelist think about the combination of subdural and death electrodes in these situations? Yusuf, you said that in temporal lobe, you would say it's a mistake to do a combination of subdurals and death electrodes, but do you think in other brain regions, like when you have to do a mapping, it's a possibility to do a combination procedure?
So initially, we used to do subdural and depth electrode in combination with placement of the subdural using with placement of the depth electrode using navigation. Now I believe I use either subdural or depth electrode and or SEEG, and we don't combine them. This is this is our philosophy. In the temporal lobe, I don't I don't use subdural and depth electrode because I believe that the subdural can change the position of the depth electrodes.
Thank you. We do this.
This is my preference.
Thank you. We switched completely from subdurals, or almost completely from subdurals to SEEG in 2013. I have done a few subdurals after that, but I never ever combined it. But I think you have some experience with that, Christian, don't you?
Well, as almost everybody else, we did subdural for a long time, and then we changed to death electrodes. And in this transition, we did some combination procedures. So, for example, when we had to map language, then we did small grids and then some death electrodes, for example, in the temporal lobe. We never combined subdurals and death electrodes for temporal lobe exclusively. But in the cases where we did a mapping, we used combination small grids or strips and death electrodes.
Okay. So, Berto, can I ask a question to
Sure.
Dr. Mayer?
Sure.
So, Yusuf, I was very impressed about your cases in the Rolandic areas and guided by subdurals. The subdurals will define the two-dimensional aspect of the resection at the surface of the Rolandic cortex, but there is no information about how deep, what's the depth of this 3D volumetric resection that you're based on a 2D method. So I wanted to grasp your experience in how you decide how deep you go in resections of the Rolandic cortex and how this defines a better functional outcome by preservation of the white matters in that location. So what is your tips or how you define how deep you go, even without having electrophysiological information from that area in order to preserve the functional fibers and preserve the function and treating the epileptogenic zone?
Thank you, Jorge, for a very important question. So in the Rolandic cortex, after putting a grid, we perform surgery awake in most cases. And so we use subcortical stimulation. First, you are guided by the depths of the sulcus. So the depths of the sulcus, the precentral sulcus, the central sulcus, and the postcentral sulcus are very deep. And you can go all the way, follow the sulcus in the depths till the end of the sulcus, and this is where the corona radiata starts. So the first indication is the depths of the sulcus. The second indication is stimulation. Subcortical stimulation is usually of lesser intensity, far lesser intensity than cortical stimulation. And so, for example, if I'm using 4 milliamps on the surface, and 1 or 2 milliamps would be sufficient to stimulate the internal capsule. And you need, if you are, let's say, doing a resection in the face and hand, you need to stimulate, find the leg area, so the leg fibers. When you start getting leg responses, it means that you are in the internal capsule, or deep corona radiata, and you need to stop. Similarly, you ask the patient all the time to continue moving. You ask him to move his leg. When I'm doing surgery in the supplementary motor area and motor cortex, the structure that is, in the interhemispheric area, superior convexity interhemispheric area, I start the resection at the motor cortex, not in the supplementary motor area. So in the posterior extent of the SMA or motor cortex, because if you start the resection in the SMA, you will not have any more responses to rely on. So I go all the way deep into the corona radiata, do the initial resection, put the posterior part of the resection, and then proceed anteriorly into the SMA area, again, to be able to carefully use subcortical stimulation. Also, navigation can be helpful, but you have to account for brain shifts, etc. So the combination of all these things.
Thank you.
If you injure the internal capsule, no recovery is possible.
Thank you.
If I can add another one more little comment, I completely agree with you, Seth, that the most important point is the depth of the sulcus. Especially if we are thinking, if we are talking about clear-cut focal cortical dysplasia seated in the primary motor cortex, and if it is clear-cut, it will be a type 2 FCD. First, consider that you will have no function inside the focal cortical dysplasia. Be careful, I'm talking only about type 2 cortical dysplasia. No function. If you stimulate the dysplasia, you will have giant evoked potentials, you will have abnormal motor responses, but this does not mean that you have function inside the dysplasia. So those are the most simple cases. Clear-cut dysplasia that if they are a bit large, probably they will be also much more stiff than the surrounding healthy brain. So it's very clear to understand that you are resecting a dysplasia and you are not touching the normal brain. Subcortical stimulation is, of course, very important for the white matter tracts, but not important before reaching the corona radiata. So again, the depth of the sulcus is one of the most important guides.
May I ask the panel 2 questions?
Sure.
It's nice to see, Chico, one of your slides showed that you're doing less and less invasive and focal cortical dysplasia type 2, for instance. And the question is exactly towards this. If you have a patient that that you clearly see on MRI as cortical dysplasia, very nice to be cortical dysplasia, would you go ahead with imaging without any invasive recording, or you still record these patients invasively, or is there any type of those patients that you do and the others that you do not?
If the focal cortical dysplasia is clearly visible with well clear borders, and if the position of the cortical dysplasia is strongly coherent, of course, with the semiology and with the non-invasive EEG, we absolutely go on without any invasive recordings. On the other side, we still do invasive recording when the borders of the dysplasia are not so clear, so you have a blurring of the edges of the lesion, and the lesion is close to eloquent cortex. In this case, even if the semiology and the non-invasive G are well concordant, sometimes we still prefer to do invasive recordings with the SEEG electrodes to define better the edges of the lesion, and also because, who knows, we could be lucky with the thermal ablations, radiofrequency thermal ablation, and if we are lucky, the patient is even much more lucky than us.
Would Youssef and Jorge comment on that?
Well, I agree with Jorge that a significant portion of cortical dysplasias in the Rolandic area can be removed without any neurological deficit. So you would map the, I have a bias, I use a lot awake craniotomies. So you would map the cortex and you would map the dysplasia, and there is no function in it, and you remove it. It can be located in the hand area or the face area, and you have no deficit at all. What I described is resection of dysplasias that are associated with function. So the patient has a deficit immediately after surgery, and then recovery of the deficit subsequently.
So you, can I ask you, so on that second point, because in that patient you're describing somebody who has function associated with a less discrete dysplasia, during surgery while you map, that patient is going to see a decrement in function.
Yes, absolutely. Definitely.
And so how are you deciding which of those patients can recover function and which of those patients you're worried may not recover function?
That's a very important question that you need to discuss very, very extensively with the patient and his family prior to surgery. So I tell them, initially, I warn them that they are going to have a dramatic deficit, and I show them videos of my patients who have recovered, and I tell them.
We just lost your audio.
Sorry, I don't know where, I interrupted.
You will tell the patients and you'll show them a video.
Yes, so I show them videos of my previous patients, and perhaps one, if there is an opportunity, I can show you far more examples of this. And so I tell them that they are going to have a deficit, and if they escape from a deficit, I think that's that's good news for them and for me. If they have a deficit, they would have been warned. And, I tell them that if they undergo rehabilitation, they will recover. If they are lazy and do not undergo rehabilitation, they will not recover. The recovery is commensurate with how much the patient puts in his or her recovery. So it's very important that they retrain their remaining central cortex to what we call vicariate and take over the function of the missing cortex.
And do you think if the resection involves more than just primary motor, if it involves part of SMA or primary sensory, are they less likely to recover?
So the patient who recover the less or take a long time to recover are when the resection covers motor and SMA. These, in my opinion, or in my experience, I should say, take much longer to recover. The patient who have sensory deficit, those who have a sensory deficit of the leg, far more complain than have a sensory deficit, I mean proprioceptive deficit of the hand. Because when you walk, you need to have a proper proprioception of your leg. So they walk and they continue for many months to complain that they lack proprioception of the leg. The problem is speech. So dominant face area carries various representation of speech. So I mean the face area. And in these particular patients, I cannot predict how much speech deficit they can have on the dominant cortex, and that's why I find it's paramount to do it very carefully under local anesthesia.
Thank you.
Thank you. I know it was a little bit off topic, but there were some audience questions too, so I just wanted you to clarify. So
Thank
thank
you.
So, I mean, we have the time is 5:35. Should we take the audience questions by email or? And Guy, you have a question?
No, that was my question. I think maybe we can forward the rest of the questions to the speakers.
Yeah, we can do that.
Sure.
I think the most important parts have been discussed, and very many important questions in this aspect has been discussed in a very good way, I think. So we will look through the remaining questions, and we will try to forward them to the speakers and perhaps to the panelists also. And we will try to give individual replies to all the attendees. So thank you very much. And do we have a date for the next time, Guy? You have it, or Christian?
It's 1 month from today.
Yeah, that's right.
The 21st.
Yeah, okay.
And the next topic will be laser ablation.
Yeah. So thank you so much, all
Thank
of
you
you.
for the privilege.
Thank you.
Thank you.
I will be opening the post-webinar room.
Okay, I will be there in 2 minutes. Thank you.